Now we have the next IC, and the instruction course is on the horror shows in cataract surgery. And we do understand that every one of us at one point of time or the other, during a cataract surgery or before the cataract surgery is done, during a pre-operative evaluation, have horrors and chills running down the spine. And the horror can be more so while the surgery is going on. When you are face to face with something that you did not apprehend, something that you did not know, and something that was inadvertent, how to go about those situations. And we have a great faculty of Dr. Arup Bhaumek, Dr. Meenu Mathan, Dr. Ritika Sachdev, Dr. Ashish Majumdar to tell us how the horrors have been tackled, how they have tackled the horrors in their surgical experience. So without much ado, I would like to request Dr. Meenu Mathan, Dr. Ritika Sachdev, Dr. Ashish Majumdar, and Dr. Arup Bhaumek to the stage and to the podium, to the stage, and give them a big hand of applause, because these are people who are really good at very difficult situations in cataract surgery. So I'll start off with my part of the difficult cataract surgery, and that's a traumatic cataract. And believe me, when traumatic cataracts come to your clinic, I'm sure every one of us has the experience. But what is very, very important is a very good preoperative evaluation. And ocular trauma, if you really think how to be, and with the present day times, it is becoming relatively common. And can you believe this? 1/5 of adults experience ocular trauma in some point of their lives. And it's more frequent in young men and women. Now, there was a study performed by the WHO, and it was estimated that 55 million eye injuries occur annually worldwide. So this is something that we are going to face as ophthalmologists in our clinics. And up to 1.6 million lose their sight due to eye trauma. So in developed countries, it becomes a major cause of unilateral blindness, and because of the road traffic accidents that are becoming more and more during these times. So what happens when there's a traumatic injury and to the lens? There could be subluxation or dislocation. Of course, because of the trauma to the lens, there could be cataract, and there could be a phacomorphic glaucoma because of the swelling of the lens. There could be rupture of the material of the lens and the lens fragments, and glaucoma can result. And there could be trauma to the other structures. So this is a very important point, that if the eye is traumatized, and if you find that there's a cataract, be sure that there will be some other structure that is traumatized as well. It can be the optic nerve, it can be the sclera, it can be a posterior scleral rupture, it could be the angles, angle recession. So everything right from the cornea to the optic nerve has to be ascertained. And of course, if it's a road traffic injury, the orbit and the brain also has to be taken into account. So trauma which forms a cataract can be either a blunt or a penetrating cataract, penetrating injury which can cause a cataract. So again, the role of the ocular examination and how to rule out an opal globe injury, and to look up for the intraocular pressure, whether it is high or whether it is low. Both are very, very difficult situations and have to be assessed. The retinal status, yes, if you can see the view of the fundus, is great, but if you cannot, you have to depend upon the ultrasound. And a good ultrasound can elucidate many, many aspects. The retinal status has to be ascertained, and of course the RAPD, the pupillary reaction, and that is so important first and foremost to rule out a nerve injury. Perception of light and projection of rays, and prognosis for the visual outcome. For ultimately, you've got to say, after doing surgeries, after treating the patient, what is going to be the visual outcome. And that's a commitment that you have to give. It has to be guarded. The other thing that I would always stress on is an evaluate. If it's one eye injury, the other eye is 6, 6, and 6, yet there should be a perimetry done for the other eye, which is not traumatized, and it can give a lot of assessment about any other optic nerve injury that has taken place. So in such cases, how do we place the intraocular lens if there's a cataract? And the capsular bag, if it is complete, then a single piece acrylic intraocular lens can be placed in the bag. However, if it is ruptured, and we'll show you a quick few videos, a 3-piece acrylic IOL should be placed in the sulcus. Preferably, if it can be placed in the bag, can also be done. That depends upon the judiciousness of the surgeon and at that point of time what is happening. So the anterior chamber lenses, please avoid, please avoid. If it is not manageable to put in an intraocular lens at that point of time, leave it to the VR colleagues who will do a secondary IOL once the whole cataract has settled. In case of no capsular bag support, of course, a scleral fixated lens or a glued IOL has to be taken up. Now, I'd like to show this extreme, horrible cataract situation in which this patient sustained a trauma nearly 10 years ago, waited all the time, and this was the look of the cataract that it was. Now, it was a deep, dense brown cataract. Half of it was subluxating in the anterior chamber. So we placed the high molecular weight viscoelastic, and then so that there was a space created. And after that, we placed the trypan blue and plastered the trypan blue over the capsule so that we could stain the capsule. This is something that we don't do all the time, but we did it this time because the shallow anterior chamber would otherwise make the capsular access very difficult. The capsular access we could do well, and then we placed the capsular hooks. Here again, the atraumatic capsular hooks are very, very important. And once you place it, your bag is stable. You can go ahead and do a little the maneuvers that are needed for this particular eye. Now look at this, we are placing the CTR because it is already a subluxated lens, and if a CTR is not placed, the bag position is not going to be proper. So despite the fact that I would be entrapping the cortical fibers when I'm doing a cortical cleaner, we did place it in the bag and in this stage, and see how nicely it has actually centered the whole bag. Now the next tough choice, and here this is an older video, and I'm using the Infinity machine, which does not have the great advantages of the newer machines, but yet it was a very good machine. So we went in layer by layer and step by step. So, and you can see that the partitioning off is coming off from the periphery. So the periphery gets detached and we are able to do a direct chop. The peripheral cleavage line comes up, and then small pies at first need to be taken up and to be emulsified, which I do, and gradually with viscoelastic coming in, supplementing all the time. So we are able to put in the viscoelastic and have a stable anterior chamber, which is also important in such cases. So once the anterior chamber is stabilized, before taking out, of course, the phaco needle, put in viscoelastic again, and placing an intraocular lens, a single piece lens in the bag is not so difficult. It can be placed nicely, it goes in very well, and this patient was now doing quite well. But we had a subluxation that was nearly 180 degrees. So we had to do something about that. So we had the Sionis ring and the segment. Now what happened is at this stage, the Sionis ring that we had fell down and we did not know what to do about it. So we had, our theater nurse said that she had a broken Sionis ring, which could it be used? So in this point of time, we use this broken Sionis ring, remembering the fact that the broken edge would have a very sharp end, and it can go and puncture the capsule, and that would be the end of the surgery, more complications to the surgery. But God willing, it did not happen. We could place the sutures well and a well-centered bag. The next video that I would like to show you is again a traumatized lens, and this is a young child. And so we go ahead and do the surgery. Now, everything we apprehend, we know that it has to be a well-centered rhexis, so we put in the mark on the cornea. And the first thing that we do is to take off this amount of synechia that there is, and then place the trypan blue. We need to stain well, and it is already a bulging lens. We do not know how much of penetration this lens has gone in, but here we use the micro forceps. And with the micro forceps, I have to be very, very careful that I do not go to that punctured area. So I'm lucky that the punctured area is approximately 2 millimeters away from the pupil center. So placing the viscoelastic time and again, and you can see that I'm trying to do an eccentric capsulorhexis, anterior capsulorhexis, and nearly succeeding it. And if I do not succeed, and if I go into that area of fibrotic anterior capsule, then I'll have trouble. So you can see the eccentric rhexis that there is. I want to make it a little larger. So going in with the micro scissors and fashioning it as much as possible, leaving behind that part where it is fibrosed capsule and where the synechia was. So now I'm still not sure whether the puncture has gone right through into the posterior capsule, and we do not have a integrity of the posterior capsule. We do not know that at this stage. So very gradually, very slowly, we take off this nucleus, and the nucleus removal and the cortical fiber removal is not difficult, but we have to be very, very cautious that if there is dehiscence of the posterior capsule, this has to be taken into account. And that's the last part that we are negotiating, and we do face trouble there. But gradually, with time, and being very judicious with the viscoelastic, which is a very, very important part. So as you can see that I'm opening up that part last, and things look well. So placing viscoelastic in the bag, and then we need to do a posterior capsulorhexis in this stage. As I said, it was a child, and this posterior capsule is going to opacify. The integrity of the posterior capsule was there, so that was a saving grace for this patient. So we fashioned a posterior capsulorhexis with the micro forceps and placed an intraocular lens in the bag. So God was great, and the ghosts that were there was eluded, and we could get a well-centered IOL in the bag with a posterior capsulorhexis in this child. So this just goes to show, and of course to complete it, we did an anterior vitrectomy and cleaned up and placed in tricot, which is 100% must before you close the wounds. And it is the savior up there and who dispels the ghosts and the horrors of such cataract surgeries. So the completion of the surgery, the intracameral antibiotics should be administered at the conclusion. After closure, the surgeon should assess leakage, and a suture has to be placed if it is required. Post-operative management of the traumatic cataract includes the topical antibiotics, steroids, and cycloplegic agents. Of course, in the two cases, we did not have a good view of the fundus, and thereby we relied on the ultrasound. But at the conclusion of the surgery, definitely we need to take the indirect and have a look at the fundus with the media very clear, and to assess the fundus details. So this is what I wish to present. Thank you very much for your kind attention. I'll ask Arup to go on to the podium as the next speaker. If you have questions, do ask. Unfortunately, I have another course that is, clashing with this. I will leave, but I have better people on the dais in the form of Dr. Meenu Mathan, Dr. Ritika, and Dr. Ashish. So they will take the course forward. Any quick questions you have, I'd be happy to answer.